Welcome back, everyone. I hope each of you were able to take advantage of our short break. I'm going to hand it over to our chair, Dr. Claus, to introduce our next session and speaker.
Thank you, Emily. So I'm very excited to introduce our next guest, Dr. Christina Weyer Jamora, who I know as both a friend and fellow researcher. Dr. Jamora is director at the University of California, San Francisco Neurocognitive Care Services. And more importantly, she's just a wonderful clinician. And I've been very excited by recent findings that she and her colleagues, including Dr. Jenny Taylor, Dr. Suzanne Chang, have identified in trying to relieve some of the symptoms and neurocognitive issues that glioma patients, including lower grade glioma patients, face. And some of what they found was actually kind of happenstance and having to pivot and manage things during COVID, but working towards creating perhaps some sort of an online version of making things better for lower grade patients. And we're actually hoping to partner with she and her colleagues so that we can perhaps offer some sort of trial or way to work this into the local glioma registry. So Dr. Jamora, to you.
Oh, thank you so much, Dr. Klaus. It's always wonderful to be, be here with the tribe of low-grade glioma and trying to help understand how to be of service and how to help manage challenging cognitive changes that come along. And so it's been really exciting to hear the talks today and a lot of the science that's on the forefront. And as we begin to turn low-grade glioma into a chronic disease that people manage, we need to also have really good ways in which to live well despite some of the common cognitive and emotional changes that come up. So I'm happy today to talk a little bit about that and see what we're learning so far and what's also on the horizon. And I too am very excited about our upcoming collaboration and what the future of science may hold in terms of changing the way in which people manage some of these cognitive symptoms. So I say off we go. Let me see if I can get this remote control to work. Oh, yes, I did. Okay. So I don't have any disclosures. I do have a number of advisory boards that I'm a part of, and a little bit of some of the companies that I work with. However, none of what I have today really is in conflict with that, or I don't have any disclosures in terms of some of the content that I'm presenting today. So what I'd like to do is really discuss an overview of some of the common cognitive changes that are associated with that we see in low-grade glioma. And you'll hear me talk a little bit about what my patients talk about experiencing, because oftentimes I feel like that they really are the best to tell us what they experience, and then how we understand that scientifically, and then of course more importantly what to do about that, and then talk about those strategies to optimize day-to-day functioning and independence. So thinking changes are very common in LRGG, and we know that they're oftentimes linked to lower quality of life and shortened survival. And one of the things that I think that folks that I work with over and over and over say that sometimes the changes that patients experience or they talk about can seem somewhat invisible to some typical methods of assessment, cognitive screening, and they'll experience feeling slowed down, or they'll experience having trouble to be able to, whenever they go into another room, and they'll forget why they're in there and what they went for. And those symptoms are common across the human experience, but particularly so in someone that has had a brain tumor and brain tumor treatment. And this and as the advances in resection and management have improved, we have begun to think about, well, there's sometimes for some individuals there is residual cognitive changes, thinking problems, forgetfulness, distractibility. How can can we address some of those issues so that way people can thrive in the bloom of their lives and be able to enjoy important things in their life, things that are valuable to them. And so I think that cognitive rehabilitation is something that has been around for a very long time and has often been utilized and popularized in traumatic brain injury and stroke. And I think that more recently, probably in the last 5-10 years, we've begun thinking about the use of cognitive rehabilitation in primary brain tumor patients, especially those with LRGG, and understanding that it now does hold some promise for improving cognitive processes in low-grade glioma. So I think maybe we can start with understanding some common thinking changes that are common to LRGG, and also how cognitive rehabilitation can help. And if you don't have access to cognitive rehabilitation, what are some practical strategies to think about from the literature and inform ways to kind of going about it differently, even if you don't have access to more specialized care? So thinking changes, as I said, are very common, and there's a lot of different reasons for that. It isn't just the tumor or the cancer in and of itself, and it isn't just the tumor treatments. We know that there's a wide variety of individuals that even after they have surgical resection, not everyone experiences complete remission of their cognitive symptoms, and it varies. And and we're still really trying to understand why that is, why it is that there is such variability in terms of residual cognitive changes after surgical resection for some individuals. But about 92% of individuals throughout their course will report experiencing some changes in mood and or thinking. And that might be forgetfulness, that might be slow thinking, having trouble keeping up in conversation, having a hard time multitasking. You're doing something, your child comes in and asks you a question, you're like, I can't do both things. Let me finish here, and then I'll attend to your question. Those are very common things that I sometimes hear, or having a hard time with being able to remember a word or describe something. So there is a myriad of reasons why individuals will experience these exacerbations or these worsening of cognitive symptoms. Sometimes it's that they are healing from radiotherapy and from surgical resection, and they'll have worse symptoms in that period. And then they sometimes will start to settle down. Sometimes they're on medications and have medications that can negatively impact their cognition. So some types of steroids and seizure medications, sometimes that can lead to worsened expression of cognitive symptoms. And or some, for example, medications with anticholinergic effects, those also for some individuals can lead to worsened cognitive expression. Sometimes also individuals have a prior history of lots of other medical problems that can negatively impact the vasculature of the brain, for example. And that can lead to additional burden and difficulties in having full recovery. So there's lots of different reasons why individuals can have thinking changes, and it is important to be able to acknowledge that even though those changes, maybe other people have a hard time seeing it, we know those changes are oftentimes common in this population. So whenever I say thinking changes, what are some of the things that are common? So the most common changes that we oftentimes see is attention and concentration, memory, executive functioning, and processing speed. Now, some people, depending on the tumor location, they can also have very specific changes, such as having trouble using their words or understanding words. Or they might have, for example, they don't necessarily see one side. They might have what they call a field cut. So there are specific things, but across different patients that I've seen, and the hundreds and hundreds of patients I've seen, most patients, they'll begin to talk about, I just get distracted really easy. And whenever there's a lot of environmental noise, I just have a really hard time focusing, or I just have a hard time keeping up in conversations. And when multiple people are talking, it's very hard for me to kind of keep up the cadence and put together what everybody is saying, and then also come up with a response myself. in a kind of rapid way, having a hard time multitasking. Sometimes people can have behavioral changes too. They feel like their get up and goes, got up and went. Their motivation is just not there as they were before, or have a hard time. They do better with remembering information if it's written down, or they do better when they have reminders. Those are all very common symptoms that people that struggle with primary brain tumor have, in particular people with low grade. So what is cognitive rehabilitation? So it really is a systematically applied set of behavioral interventions designed to help individuals live well and learn ways to manage their cognitive symptoms. So some of that means we're actually retraining a particular cognitive area. So, doing attention and concentration retraining. There's some evidence to support some types of computerized retraining can help that if, for example, working memory, it's a particular type of complex attention. However, we also have to take that and put that into the context of the things that are important in people's daily life. It might not be interesting to you to get better at a particular working memory task. But what it might be important for you is to be able to make sure to try to, whenever you're talking with your children, that you can track the conversations. That might be important. So we know that working memory has a component of that. So making sure the cognitive rehabilitation, for example, focuses on compensatory strategies, which means figure out ways to work around the challenges that you're experiencing, which might be organizational strategies and different ways in which to think about using problem solving or other interventions. It also includes embedding the emotional, the emotional and coping strategies that sometimes that can lead us to have worsened cognitive changes as well. So if we're feeling quite distressed, we can experience more exacerbations of distractibility, for example. So, and making sure that patients and families have the education information that they need about what exactly is going on, when it goes well, why, and then, what cognitively we can do to address some of these issues. So all of those things are considered cognitive rehabilitation. A little education to understand where you're at and what areas that you do well in, and how to utilize that, that strength that you have with, situations that are more troublesome, doing some retraining, improving that kind of cognitive gas tank, so to speak. So that skill in and of itself is a little bit better, but then using strategies to figure out how to then utilize that bigger gas tank of cognitive improvement to things that are important to you, such as a speech at your daughter's wedding, or being able to make sure to do things in your daily life, such as work that's important to you, but then also addressing kind of some of the coping components of it as well. So there is now some in the literature more evidence for the use of cognitive rehabilitation in brain tumor itself. We're still trying to understand what exactly is the mechanism by which people's cognition improves. Because as we know that people will continue and often will have more cognitive changes as time goes on, there's a subpopulation that happens for. And so we're still trying to understand, but our best understanding is that it's based off of that the brain can remodel itself, and that is neuroplastic, so to speak. So it can, if we're giving it adaptive strategies, and it's using those adaptive strategies, it's more likely to lead to cognitive improvements and some functional improvements in one's daily life. But we're still understanding what structurally is happening in the brain, if anything, to be able to validate on a biologic level what cognitive rehabilitation is doing. So we're excited for some upcoming research that may be investigating that. So can cognitive rehabilitation actually move the needle? So that's a question that I have, because sometimes we can feel we're better, but does what does the objective evidence say? So at least in our, this is our recent clinical trial. One thing that we have found through the use of something called goal management training, which is a manualized treatment of cognitive rehabilitation in individuals, that we can improve something called working memory, which is complex attention, in the context of cognitive rehabilitation. And that makes sense on a practical level as a clinician to me, because I think about working memory as something is a process that is distributed in multiple areas of the brain. It's not like localized to the frontal lobe, or it really is this complex process, and that it's a more malleable cognitive skill. And so it is something that we see across many different neurologic disease types as something that can be intervened upon and improved. So I was grateful to see these findings that we also in brain tumor as well can interview and can improve something such as working memory, and that it isn't so discrete that it can't be, or explicitly inaccessible that we can't improve that. But then what does then that mean for someone's daily life? So some of my patients say, well, Dr. Day, it's fine that you improve my working memory, but my working memory is really interesting to you, but I don't think that it's all that interesting to me. So what I want to do is return to work. I'm 30, I have children, I have obligations. I need to get back to work for as long as I possibly can. And I think that's an absolutely fair point. And so one of the things that we've been looking at is some of our data in terms of return to work. And so one of the things that we know in rehabilitation is whatever you practice, you get better at, but it doesn't generalize to other things. So if I get good at working memory training, that will make me better at working memory training, but it might not make me better, for example, at my job place. And so we wanted to take a look at some of our data. We have a return to work protocol that we do for folks that are eligible. And that one of the things that we saw is that if you do specific types of work-focused cognitive rehabilitation, this was all over, telehealth. And so whenever we had individuals with that were in our sample, 87% of the people that had this very specific work-focused cog rehab improved their work status. They got back to work, they got off their performance improvement plans, they were able to really thrive in the workplace. Compared to those without care that didn't go through that, or that had more general kind of cognitive intervention, only 34% of people were able to do so, which is really pretty consistent with the literature. It's a little bit lower than the literature, but I think that it is something that we typically see. So I think the take-home message is that it's important to try to practice the things that are important, while also acknowledging that cognitively, that cognitive rehabilitation can change some domains, or there's some promising evidence for it. However, it might not have the overlap into the daily life, which I think is important. One of the important factors for seeing a rehabilitation professional. And I think the other thing is sometimes we get that question of, well, I don't think my patients are going to like cognitive rehabilitation because you're poking on their cognition, you're talking about hard things. And one of the things that I want to make sure is that it's useful and helpful, and people find it to be additive to their care. And so this was some feedback that we had gotten from patients about the goal management training, in terms of, we said, tell us what you think about this. Is this acceptable to you? Is this something that you would want to do? And by and large, you can see here that it was really a positive experience that patients had reported having, that they really liked having specific strategies to be able to utilize in their daily life to address challenges that they were experiencing, that was very practical and applicable. And that the major downsides that oftentimes people had experienced is that they just wanted more sessions. They wanted to continue the work past what the clinical trial had offered. So we're truly trying to figure out how to make that happen, in the context of resources. So, I think that one of the things but if you don't really feel that you need it at that time, then it's probably not the best intervention for you. It's not a be all end all for everyone. So, I think that's the other thing that we see in terms of some of the data that, if this is something that's really important for you and it's a priority for you, it's really important to, go ahead and pursue it. However, if there's other competing demands that you have, not kind of doing cognitive rehabilitation at that point may be better. So a lot of the folks that I work with, my colleagues, this is something that's cognitive rehabilitation is very new in the field of brain tumor. It's been around for a very long time in many other neurologic diseases, but oftentimes I get this question of, well, I don't have access to this. This is a very kind of, we have access to this at UCSF and some of the other large centers, but not everybody has access to this. So I always like to try to do some thinking together with folks about, well, how can we work on, or how can you begin to think about working on some of their thinking skills when you don't have access to some of this more specialized intervention. So one of the things is just kind of thinking about, so I put my nursing hat on, one of the things that I think about is trying to figure out how we can just begin to think from a practical perspective, how we can risk reduce some of the things that we oftentimes lifestyle factors that come up in our daily life that don't really support brain health. So for example, having a hard time with managing one's relationship with substances, having uncontrolled drinking, for example, that can be very hard on the brain and can be very challenging in terms of being able to live well, and that also can negatively impact one's sleep. So should you not drink any alcohol? I'm not saying that at all, but staying within some healthy drinking limits. And if you're having a hard time with managing those things in your life, making sure you're talking with your doctor and getting some help around that. We know that exercise is a huge component of brain health because the brain is very vascular, and having that exercise does help on many levels in terms to improve brain health. Getting good sleep, making sure you're managing other medical issues. All of those things are very important. And also, for example, avoiding traumatic brain injury through falls. So avoiding some safety and risk issues. We know that sometimes being unsteady on one's feet can be quite a common symptom, which can lead to further injury. So, and socializing and novelty and making sure that we're taking care of ourselves in terms of coping. All of these things are, I think we've all heard about these things, but they are crucial pieces to the pie in terms of places to start from and thinking about ways to optimize these existing things in one's life to be able to support brain health. So sometimes people say, well, I've done all that. Now, what's next? Lay it on me. What's next? So one of the things that oftentimes people come with as a more common symptom is fatigue and sleep issues. So we have a recent systematic review that's looking at the overlap of cognition and fatigue. And one of the things that keeps coming up again and again is that fatigue and cognition have a little bit of shared relationship, but they really are in some ways a bit separate from one another, from what at least the current literature says. But one of the things that's really helpful, for example, for managing fatigue, according to the NCI guidelines, is something along the lines of having a good, robust exercise that you are doing to the best degree that you can a few times a week, and managing that in large measure will help with the fatigue. And for sleep, I also think about the type of sleep issues. Is it an obstructive breathing issue that you need to kind of get further evaluation with your primary care provider? Is it a circadian rhythm issue that you're having trouble with? Your days and nights are kind of mixed up, or is it something there was more sleep behavior issues where that cognitive behavioral therapy for insomnia, for example, can be helpful for that, or being able to kind of have good sleep practices around bedtime. Starting with fatigue and sleep can really help you feel like a little bit better version of yourself. One of my patients had said, well, if I'm not sleeping, nothing's good. So if sleep's not good, nothing's good in my life. I really got to make sure and make that a priority. So starting with that, I think, can be really, really helpful. And in the end of this talk, you'll see some, you'll see we put together kind of a booklet around strategies that you'll have available to you for management of fatigue and sleep. So strategically starting your day and having a system to help get your things done. So sometimes I used to start my day just with email and I would just let my day run me. Instead, now I kind of do a little bit more practicing what I preach, where I'll kind of start my day with surveying, what do I need to do? Or even the night before, and driving what I need to do based on urgency of needing to get done and having a more strategic approach to my day. And then also deprioritizing if I can't get it all done that I thought I was going to have it done. And then consistently using a system. Is it calendaring? Is it reminders in the calendars? What is it, a list that you have going in your kitchen for all of the things that need to be bought at the store, and then you take that list. All of having a quote unquote system can really help reduce the load and track all the things that you need to get done. And being present during tasks. So sometimes we're so kind of focused on all the things that we have to do that we're not really totally paying attention in the moment of exactly what we're doing at the time. So practicing some of that present focus when you're doing tasks can reduce the kind of loss of information and the and having a hard time with being able to track what one's doing. And also learning from successes and challenges too. That sometimes I'll even I have a tendency to track. Okay, well, when it went well, what was it that helped me make that happen? Okay, well, I got my bag together the night before, and I looked at my schedule the night before, so that way I was prepared and have my laptop all plugged in and ready to go. And I had my bag. All I had to do was just leave. Versus if I didn't do any of that pre-preparation, then I would be running around like a chicken with its head cut off, trying to find my keys. And, as I was trying to walk out the door and trying to answer phone calls and all of that. So being kind of a little bit of your own scientist of knowing what works for you and trying to make that a more consistent part of your daily routine. And you yourself are your expert more than all of these experts, and trusting that you and your family can help think through this together. And then, of course, considering that feedback from others. Sometimes others see things that we can't see ourselves, and trying to make sure that we're making them part of the solution too, if we can. So cognitive stimulation is something as someone that's worked on the inpatient side and also now on the outpatient side, that I've seen time and time again over a number of neurologic diseases. And this overstimulation idea is something that comes up quite a lot. Noise sensitivity, visual clutter sensitivity, having a hard time with just managing the amount of information coming at you. One of my patients said, it just feels like a fire hose. I'm drinking from a fire hose, that I have all this going on and it's just not sticking. And my battery just gets drained and I just feel exhausted, and it takes me much longer to be able to recover from that. So preventing that overstimulation, knowing that what that looks like for you when you start to feel kind of tapped out. And these are some of the things, at least from our understanding, that have helped, both what patients have said, but also kind of some of the things that we're finding in a more kind of evidence-informed way. So reducing light and noise and reminders and dinging on your devices, increasing your daily structure so that you have a routine that you follow, so you're not having to reinvent the wheel all the time, or making sure that you're giving yourself extra time, twice the amount of time. One of my patients said it takes twice the amount of time to get half as much done. And I just need to really be able to kind of prioritize and set limits on the things that I can't get done. Limiting the people and places and things. Sometimes that big party is maybe not going to work for you. And instead wanting to have, quiet time in the midst of that. If you do have to go, having a little quiet time, finding a way to kind of have a little bit of one-on-one time with folks, or when it's more quiet. One of my patients also used, for example, noise canceling headphones in the house, and at the end of the day, whenever their kids, everything was kind of bouncing off the walls, and everybody in the house knew then, okay, mom's taking a kind of a brain break. I need to kind of slow my roll in terms of additional request at that point. And that really helped that family kind of manage that oversensitivity that comes up. And being able to do some cognitive rest and pacing can be really helpful too. So these are some very classic kind of recommendations that many of my patients have said again and again are helpful when they're, for example, feeling distracted and having difficulty finishing a task. So making a manageable to-do list prioritized by urgency. So what I need to get done today, what I need to kind of get done by the end of the week, and what is kind of on my radar, but not really doing. Sometimes I can only do 2 of those categories. I can only think about what I can do today and maybe what needs to be done later. But being able to do that, keeps me from having to track it in my mind. And instead, I'm having it somewhere for me to go back to. And prioritizing by urgency allows me the permission not to focus on everything at once, and kind of keeps me from getting a little overwhelmed with all I have to do. And having focus time where you're kind of focusing on doing something for a certain amount of time, and then and instead of kind of having split tasks. So sometimes some of us will work on something, but then we'll kind of get bored with it or frustrated by it, and then rabbit hole down a preferred news site, or doom scrolling, or some sort of off tasking. So we want to be able to avoid that by really having a bit more structure about how we go about things, setting timers for a to-do list, getting it done, and then resting after that. And we'll talk a little bit more about that Pomodoro idea. And developing routines, designated places for things, making sure you have a time at the end of the day where you're kind of putting everything back to where it should. So that way you kind of have a maintenance of making sure that things are, and avoiding multitasking, and bringing your attention back to what you're doing at the time. Again, it's that groundedness. So having a system and working your system. Sometimes the systems that I have are not going to work for the folks that I know and that I work with. And instead, I see them as their own best expert. And really, I encourage them to do a little bit of thinking about when it works, what helps them. And then there can be this idea of wanting to make it perfect, or wanting to optimize it and keep changing. I try to encourage people to avoid that tendency, instead to kind of get down a system. If it's using Google Calendar, or if it's using a whiteboard in their house, just consistently using it is sometimes better than having a perfect system. And we can oftentimes get overwhelmed with how much we have to do. And that's usually a sign. And so whenever I start to get overwhelmed and a little irritated, and then feeling like I'm just not doing well, sometimes that's my sign that, oh, I need to break it down into a smaller piece. What part of this can I do? Maybe I can't get the whole thing accomplished. And who do I need to talk with to make sure and let them know that? And trying not to keep it in my head. That's the other thing that we sometimes feel like we used to be able to kind of think of all these things and keep them all in our head. But by and large, having more, having things written down in an organized to-do list, and having them time bound, and who's responsible for it, all of those best practices, those are very common things to think about in terms of task management, but it's also something really important to think about for oneself. And being able to pre-plan and prepare in advance, and reducing the clutter and the sound as we're getting things done is oftentimes really helpful too, to reduce the load, and so we can just focus on the things that we have to do. So these are some things that are very popular for some of the patients that I work with, very very classic organizational tools, using Trello for project planning, where you're kind of having all of the tasks that you have to do. And then as you get them done, they slowly but surely drop out, but they're all tracked according to, whatever you decide in terms of time frame. Having a paper to-do list. I tend to have a paper to-do list, but it's sorted by urgency in terms of red, yellow, green. Red is I need to do it right now. I got to get this done. Yellow is, okay, well, I have a little bit of time. So it's like the yellow yield idea. And then green is that I'll go on it at some point, but it's just, I'm not there yet. And then one of my patients really liked using Google Keep in the same way because he needed it on his phone. And I thought that was a really lovely way to take some of these ideas, but also, have it there in on the go. So a Pomodoro idea is what I was talking about before, where you have 20 minutes, 25 minutes of focused work, and you plan your tasks in advance, and no sneaky work, no sneaky, resting during your Pomodoro. It's kind of like interval training for getting things done. And then you take a break. So you plan your tasks, you do something for 25 minutes, and then you take a break for 5 minutes. And in that, when you're thinking about that break, you're like, okay, am I red, yellow, green? Am I exhausted? Like I'm totally exhausted and need a longer break? Do I need to slow down for the next Pomodoro, or am I just fine? And can I just go? So sometimes it's also thinking about in that break, if you need a longer break, this is a way to kind of do it. But you're also not sneaky working during those times, but having little compartmentalized times where you're focused work and you're doing high cadence and then relaxing. The research says you're just more likely to get more done. And so I tend to like a Pomodoro approach sometimes. So this is our cognitive strategies manual, has a QR code in the front. So a lot of these, there's a lot more strategies. We put this together with patients in mind. We have a patient advisor group that we at UCSF worked with to put this together. And so I invite you to take a look at this and see if there are additional strategies in there. There's much more in there about fatigue management, ways to manage sleep, and just very practical strategies around ways to manage executive functioning problems in terms of multitasking and slow thinking as a starting point if you don't have access to these resources in your local area. So in summary, cognitive changes are common, they're multi-determined, and they are something that most folks will experience throughout their disease course. Managing just healthy lifestyle factors such as fatigue, exercise, diet, and having emotional support are really important, great first steps. And tracking what works to help you manage your thinking and any behavior changes, and then slowly but surely doing more of what works for you. And that cognitive rehabilitation, for those that have access to it, it has been found helpful, and that some of the things and you can talk with your care team about other possible resources and cognitive care providers, such as other people that may be more applicable to some specialized care, such as speech language pathology, or even some of the other types of rehabilitation, occupational therapy, if that's available to you. And that's it.
Thank you so much for your presentation. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of the screen, and we'll answer questions as time allows. So one of the first questions we have here is asking, what cognitive side effects are most susceptible to cognitive rehabilitation?
I would say the things that we see improve the most are, the cognitive domains wise. So working memory has, at least according to our data, shown improvement through the use of something called goal management training. We've also seen some improvements in functional memory. So people feel like they're remembering things better and have improvements in their daily life. And then some executive functioning changes. So the last two are more what folks report to us that they experience, and that they have improvement in their daily function. But at least from what the data that we see from our clinical trial, working memory in and of itself can improve.
Thank you so much. And can you share any advice for how patients can self-advocate when they're experiencing these cognitive side effects, but they don't seem to be, their healthcare team doesn't seem to be addressing it?
Yeah. I think that one of the major things that one of my patients has said what worked for him is that he really made sure to let his providers know how important cognitive and the thinking changes were to his daily life. So he said, doctor, I am having a really hard time managing my appointments and I'm forgetting things. And that's why I didn't show up to my appointment last time. And you're really important to me. I think I need some help with this because I've tried everything and I just can't seem to figure out how to manage this on my own. So making sure the providers know how important this is to your quality of life, I think can go a long way towards helping to support that collaborative relationship. And then oftentimes asking for something like a neuropsychological evaluation or asking for some cognitive screening with a local provider can begin to start kind of looking at it together in terms of what then is indicated for the next step. Or are there other treatments that the patient is on that they could work with, like, for example, bringing down a steroid dose or bringing down an anti-seizure medication dose, or is there another medication that they're currently on that they can reduce? So just making sure cognition is part of the conversation, I think can go a long way towards working on this together.
Thank you so much. Earlier in your presentation, when you were introducing the topic, you talked about how we're really living with low-grade glioma. It's not just a one and done thing. Or do you notice any of these cognitive side effects being late effects happening much later after treatment has been completed? And if so, how can patients access resources like cognitive rehabilitation when they may be so far out from treatment and now experiencing issues?
Yeah, I do see that. I think especially I see late effects of radiotherapy treatment for individuals that have had radiotherapy. Sometimes it can feel for patients a little confusing that I had my tumor out, I've had my treatment, and now it's 2 years later. Why am I experiencing all these symptoms? And so I think that that's a very common thing, and that's consistent with what the literature says in terms of the late effects of radiotherapy. And so in those instances, I think that it is fair game to make sure that you're getting the support that you need, either from a peer, such as what the ABTA provides in terms of peer support, and then also talking with your doctors about these late effects, from what I understand, are common, and I think that we need to have a better understanding of them. Can we get some detailed assessment? What are my options in terms of cognitive care providers in the areas? Is there something that we can work with to be able to do about this? I think those are all really important things to partner with your primary care provider or other specialists that you have on your team to make sure they can help you think through what the next natural step is.
Great. Thank you so much for that insight.
Yeah.
You shared some great tips and takeaways on, managing your tasks. Can you share any, maybe like a quick bulleted list of the top recommendations you'd have for patients who are wanting to engage in cognitive rehab at home?
Yeah, so I would say that the major things that I see that folks, the kind of low hanging fruit that I think are the major things is that, that people oftentimes can be quite focused on when things aren't going well. And that is very distressing, but flipping it around is whenever it's a little bit better, why? I think goes a long way. So, for example, maybe you had a situation where you did remember your doctor's appointments pretty well that week. Looking at those examples for yourself, those situations, and be like, oh, well, it's because I wrote it down, and oh, that medical record has reminders to send me, at the time I need to leave from my house. So that totally worked for me. So, oh, okay, well, maybe I need to just do a little bit more of that. So kind of being your own, you're your own scientist in some respects. I think that goes a long way towards you knowing what's going to help for you. And it also helps with awareness. Sometimes we don't know what we don't know. And so I think that I'm a little bit more of a solution finder rather than a problem finder. So I think that looking in your daily life for when it goes better, why, and then trying to recreate that situation over and over again in other situations, I think really goes a long way towards having that kind of self-management mindset that's needed for cog rehab. And if you're motivated to do that sort of work, then probably cog rehab could be a good fit for you. And for some other folks that are like, that's really not important to me right now. I want to travel. I want to do other things. That's also fair game. So making sure to know what's important to you and what you need help with, and when you do well, why. I think those are the major pieces that I see come again and again and again. And then there's all the specific things like exercise and socialize and, write things down. Like all of those are really kind of standard things. But I think knowing when you do things well and why it is that you're doing it well can go a long way towards helping in multiple types of situations.
Thank you so much for that wonderful advice.
Yeah.
Another question we have here is asking, in addition to cognitive rehab, are you aware of any impact that complementary or alternative treatments may have on neuroplasticity? Some examples would be diet, psychedelics, acupuncture, things like that.
Yeah, I have to say it's a little bit out of my lane. I think that in terms of the literature, I think there's some conflicting evidence. So we're still trying, because brain tumor is such a rare disease, right? So having large scale, well-controlled studies is still a little bit beyond our grasp. But in terms of anecdotally, some of the patients that I've worked with do feel like, for example, complementary or integrative approaches are really helpful to be able to help with reducing, symptom burden. So, for example, with acupuncture, the stress associated with, managing this disease can really be very, very well suited to integrative approaches. There's some newer evidence for the use of psychedelics in the context of some mood issues, some kind of more intractable mood issues. There are also other things. So, for example, marijuana, we know that there are some aspects of marijuana, for example, THC, in higher doses that can negatively impact cognition, but then other aspects like, CBD that have less of a cognitively impairing effect. So, I can't pronounce myself to be an expert in integrative approaches, but I do really, rely on my integrative colleagues, for example, Shannon Fogg and a few other folks at UCSF that we work with to be able to take this team-based approach. I really liked what some other folks were talking about in terms of that it does take a village to be able to manage this kind of multi-dimensional kind of symptom picture. And I do think we're better as a team versus individual providers. So I think the short answer is yes, all of those things are helpful. The degree to which and whom they are more helpful for still eludes me. It still eludes me, but I think that they should be tried, and then individuals can work with their doctors to figure out for them, where the juice is worth the squeeze, so to speak.
Thank you so much for that thoughtful answer. Another question we have here is asking, are speech pathologists or speech language therapists part of the cognitive rehab team? And if not, do you often refer patients that are in need of that type of support to those specialists?
Yes, I think that speech language pathology is such a crucial resource within a cognitive rehabilitation team. We recently brought on a speech language pathologist on our team, and I really love the way in which they're able to target more of the language-based issues, also swallow and mechanical speech issues. Those are not things, for example, other providers do in the same kind of specialization. So if doctors, for example, are concerned about, speech mechanical issues or speech motor issues, or more targeted or specific language issues around being able to express oneself, understand the others behind them, I think the expertise of speech language pathology is is invaluable, and can be really, really useful.
Thank you so much for that insight on speech pathology. Another question we have here is asking about alcohol avoidance. You had mentioned that that can be important. This individual here is asking about the use of CBD. Some patients utilize CBD to help with the management of other symptoms, similar to alcohol avoidance. Is there a similar risk when using CBD?
No, again, it's a little bit out of my lane, but in terms of just clinically with the patients that I've worked with, I haven't seen as much of an impact on cognition for the use, for example, of CBD. And that is something that there's a little bit of conflict in the literature, but it is a little bit more clearer that THC or the variants that have more, euphoric effects have more impact, for example, on sustained attention, verbal learning, executive functioning, of which are in many measures reversible that whenever you reduce that dose. And it's a dose relationship, higher and more significant use. And I guess and I think that what I encourage people to do on the alcohol side is just staying within the healthy drinking limits that NIDA kind of that puts down for us, so no more than 3 drinks in one setting. For women, it's no more than 1 drink a day. For men, it's no more than 2 drinks a day. And so trying to have no more than 14 drinks a day or 14 drinks a week for men, 7 drinks a week for women, and no more than 3 at one setting. And trying to and because then that physically impacts the body, which of course will impact the brain. So if you're within those guardrails, then you're probably just fine. We are still continuing to refine our understanding of it. And if you're having trouble managing your relationship with those substances, if you can't go without it, you need it to kind of get going in the morning or to do major tasks, or you're experiencing a lot of consequences from that use, then I think that that's a good opportunity to then kind of take a look at it with your doctors about, is this something that maybe needs more help managing? But I haven't seen anything in the cognitive side that would say that absolutely no alcohol is indicated. I do see some of those flashy headlines, in Google News Alert about the use of alcohol, and none is best. But I feel like that's still not a replicated result. And there are many folks that I work with that have that as part of their picture, and they have found ways to manage it.
Thank you so much. Unfortunately, that is all the time that we have for questions for this session, but thank you for your insight and your thoughtful responses. I'm going to turn it back to Emily for the rest of the program.
Thanks so much.
Yes, thank you so much, Dr. Weyer Jamora, for sharing with us the methods to improve aspects of neurocognitive function in and out of the clinic setting. We will resume the program in about a few minutes for our next session on fertility and family planning. See you back.